Hello, everyone. We are very excited to be in this webinar, Micropulse Laser for Diabetic Macular Edema and Retinal Vein Occlusion Best Practices. And we have a very esteemed panel presenters, Dr. Boris Stanzel and Professor Edoardo Midena, and myself. We would like to thank to the Iridex for organizing this and putting us together. And tonight we will have the presentations about the utility of laser and micropulse for retinal diseases, especially for the branch retinal vein occlusion and for diabetic macular edema. Please, at the end of the three presentations, there will be Q&A sessions and a discussion session, so you can submit all your questions or in the or via chat or in the Q&A box. This is a very informal session, I would say, and the goal of this session is to discuss among us about how to best use this technique of laser treatment. So I will start with the presentation. Okay, these are my financial disclosures. So the subthreshold micropulse laser is a revolution in retinal laser treatment. It has shown to be safe and effective treatment, which normalizes or restores the normal retina, and it does not destroy the retina. However, the lack of standardization has limited its use in clinical practice. If we think how we started with the retinal laser treatment, we started with the so-called standard parameters of the continuous wavelength treatment with the ETDRS. Then we used the modified ETDRS treatment, and now we have arrived to the subthreshold micropulse mode, where we do not see any clinical signs of the treatment on the retina. So if you look on your left, there is the fundus autofluorescence image of the patient that was treated with the subthreshold micropulse laser, and on the right you can see the macular grid that was performed according to the modified ETDRS protocol using the continuous wavelength treatment. So what does it mean, the micropulse mode? With the micropulse mode, the steady continuous wavelength emission is chopped into a train of shorter laser pulses whose duration, the so-called on time, and the interval, the off time, are adjustable by the surgeon. And with this shorter micropulse duration, we limit the time for the laser-induced heat to spread to the adjacent retinal tissue, thus providing more precise confinement of energy that is delivered to the retina. So we can do the multiple short exposure burns with minimal diffusion of the heat in the retinal tissue, and we have the temperature elevation only during the on phase. So it is a minimal temperature elevation, which does not damage the retina. When we treat the retina, we usually use the shortest duty cycle, so it is the 5% duty cycle, whereas if we treat the glaucoma patient, so if we perform the trabeculoplasty with the micropulse laser treatment, we can use the 15% duty cycle. So the micropulse laser is not just for the retinal treatment, but it can also be used as the trabeculoplasty for glaucoma. And recent papers have shown that it can be considered a reasonable first-line therapy with its clinical efficacy and repeatability. And that is also less expensive than the SLT treatment. So what is the therapeutic mechanism of subthreshold micropulse laser? It acts as a physiologic reset stimulus that improves and thus normalizes RPE and retinal function by activating RPE heat shock proteins. But it also decreases the production of inflammatory cytokines, VEGF, and matrix metalloproteinases. And also it has been shown that it reduces the aqueous humor concentration of inflammatory cytokines that are secreted by the retinal glial cells. So the subthreshold micropulse laser should be performed as a low intensity treatment in order to have the safe treatment, but in order to be effective, it should be a high density treatment. It means that the spots that are delivered to the retina should be confluent. And also we should use the fixed parameters when we treat the retina. Using the iridex model of the laser, we can perform the IQ 577 nanometers wavelength. We can perform different grids on the retina that can be adjustable from 2.2 to 7.7 that are as a quadrants or circular or as a triple arcs on the retina. So the fixed parameters have shown to be more secure than titrating parameters when we treat the patients with diabetic macular edema. And if we think of the fixed parameters, you can see here, these were the 100 micron spot size on slit lamp, 250 milliwatt power, and the number of confluent spots varying according to the extension when using the 577 nanometer wavelength, so the yellow micropulse laser. The subthreshold micropulse laser improves retinal function in the sense that it increases the visual acuity. It also ameliorates mesopic visual function when measured with retinal sensitivity, and also it has been reported that can give better results in the results of the visual fields and retinal electrophysiology. Several years ago published this meta-analysis of randomized clinical trials which compared the subthreshold micropulse laser and the standard ETDRS laser in diabetic macular edema in patients that were followed for at least 1 year, favored subthreshold micropulse laser over the ETDRS in the sense of increased visual acuity. So the subthreshold micropulse laser gave better functional results. So what are, let's say, the current indications for the subthreshold micropulse laser? Definitely diabetic macular edema, central serous retinal chorioretinopathy, also macular edema due to the branch retinal vein occlusion. And here I will show you just a case of diabetic macular edema. You can see here before subthreshold micropulse laser, and this is 4 months after subthreshold micropulse laser, so the edema decreased, or also this case of macular edema due to the branch retinal vein occlusion. Here you can see the OCT with the retinal cystoid spaces and also subfoveal retinal detachments, also all the microvascular changes, especially in the deep capillary plexus. This patient underwent the combined treatment, so the 3 aflibercept injections and 2 subthreshold micropulse laser, and 1 year after the initial treatment, you can see that the edema decreased significantly and the visual acuity increased and arrived to be 85-letter ETDRS score, so it is 20/20. But also, for example, in diabetic macular edema, this is one of the cases that we have published, the patients that were followed with not only OCT, but also with the OCTA, where the major differences were found in the deep capillary plexus after the subthreshold micropulse laser treatment. There are also some new reported indications in the literature for the treatment with the subthreshold micropulse laser, such as the pseudophakic and also uveitic cystoid macular edema, retinal vasculitis, macular telangiectasia, dome-shaped macula, macular microaneurysms, or macular edema associated with epiretinal membranes. So several years ago, when we compared the 577 nanometers subthreshold micropulse laser versus infrared 810 nanometers subthreshold micropulse laser using the fixed parameters that you can see in this table, we found the completely same results as far as the efficacy and also the safety was considered in diabetic macular edema. And definitely since then, when we use the yellow Micropulse laser, we always use the same parameters. So this is the pulse duration, 200 microseconds, the lowest duty cycle, 5%, the spot size, 100 microns, so the lowest, and the power, 250 milliwatt. So in DME, the indications for subthreshold Micropulse laser are the mild center-involving DME, not center-involving DME, or it can also be associated with the intravitreal injections. So in order to have the safe and effective treatment, we should use the lowest duty cycle, the small spot size. We should perform the high density treatment. It means with the confluent spots without spacing on the retina. We can perform the safe retreatment over the same area, even in the same laser session. So not just after some times, but at the same session. And we should also, in order to have effective treatment, consider retinal thickness cutoff for the treatment. And Professor Midena will talk more in detail about this. So we propose to use the fixed parameters. We should bear in mind that we need some time for retinal thickness to decrease after the laser. It's not like the injections. Now there are also available data on the long follow-up, and there are also some new reported indications. So definitely subthreshold Micropulse laser gives a faster effect on functional parameters. And when we consider the specific retinal layers where it gives the major effect, it seems to be the inner nuclear layer and the deep capillary plexus, with already reported changes in specific Müller cell biomarkers, and possibly, thus possibly with the effect on Müller cells and not just RPE. And with this, I have finished. Thank you. And now I will introduce the second speaker. It is the Dr. Boris Stanzel. He is a VR surgeon and also retinal clinical scientist with particular interest in retinal cell therapy. And he serves as the director of the Makulacentrum and the Clinical Research Center at the Eye Clinic Sulzbach in Germany. Over the past 4 years, he has performed more than 1,000 subthreshold Micropulse laser treatments for the retinal diseases. So Boris, please.
So thank you very much to IRIDEX for this kind invitation, and really great honor to speak tonight at this European webinar here about branch retinal vein occlusion. That was the theme that I was assigned to. So without much further ado, let's get into this. These are my disclosures. First and foremost, I'd like to acknowledge Dr. Van der Broek. She is a resident at the Eye Clinic Sulzbach, and she's really talented and extremely organized, and she's really helped a lot in collating the data from the patients that I'll be presenting about tonight. And we really hope that at some point we can lure her into the vitreoretinal specialty, either at our clinic or somewhere else. Okay, so we've up until now, really didn't treat a lot in vein occlusions because the literature was quite mixed about it, until we've encountered this one patient who presented at the age of 47, a male, with a sudden painless loss of vision. His past medical history was significant for non-Hodgkin lymphoma. His vision had dropped to 0.5 on the Snellen chart, and he's had this macular edema, flame chimp hemorrhages, cotton wool spots, and we ended up diagnosing with a branch retinal vein occlusion, which also had a secondary cystoid macular edema. These are his multimodal imaging. You can clearly see that he's had a center-involving macular edema, and not very high, but still. And then you also can appreciate these cotton wool spots, which probably were predictive of why he later then went on quite some significant intraretinal atrophy. And another striking thing that I'd like to draw your attention to is that he has a nearly perfect fundus autofluorescence, which is probably quite relevant to why laser might work in his situation. And so he had one problem. he's had really significant phobias from intravitreal injections. So every time he had to get an intravitreal injection, he required general anesthesia. So 4 months in, basically, he came back and was still troubled by a center-involving cystoid macular edema. And he, young guy, looked up the internet and found out for some reason that ranibizumab is better. We generally don't switch anti-VEGF agents because there's really not a lot of evidence that there is a difference between the three that are available. And so 3 shots after his ranibizumab, we had him back 2 weeks later, and he before he got these 3 shots, he talked to us whether there's something else we can do. And I told him, like, okay, well, let's see how the response is to this anti-VEGF treatments. If we can get his retina completely dry, there might be something. And so the reason behind it is simply because we felt that if the retina is completely dry, then you have a even response to the laser. In other words, the deposition of the laser fluence to the retinal pigmentilium and its subsequent effect might be quite nice. And so we then signed him up for a yellow micropulse laser treatment. And he came back then a week later, and he was really thrilled. He felt his vision is better, but we noticed that there was a slight macular edema, which wasn't there a week ago. And so because that micropulse laser treatments can take up to 2 months for the treatment to actually show up, so we opted to observe. And so we had him back then 6 weeks later. And so he then presented with a drop in visual acuity, and his edema had slightly increased just a little bit. And so we then decided really to re-inject him again under GA, but also to repeat the micropulse laser, because the patient really seemed to feel that there was some benefit to it. And so this is his OCT. Then 2 weeks after the laser, 1 month after his injection, the patient was absolutely ecstatic. He presented with a 1.0 visual acuity. His retina was entirely dry. Compare the volume scans here from just around the time of his first laser and then to now. He basically presented with a completely dry retina. We looked his scan up a little bit more, and then based on treat and extension schemes of anti-VEGF therapies, you can also inject the dry retina. So we opted to do that. We gave him another shot of ranibizumab and then had him back 2 months later, at which time he still had some parafoveal cystic change. We injected again and then had him back a month later. And basically the patient begged us, why don't we try another laser? I don't want another shot. And so 6 months after that last micropulse laser, he was still completely dry, had a 1.0 visual acuity. 12 months out, which was actually just a few weeks ago, he was still completely dry. His vision had slightly decreased to 0.8. It might have been his daily performance, which we know it varies sometimes in patients, particularly if it's dark winter times, dry eye can come in. And so this is the summary of his therapy. He ended up basically getting a total of 10 anti-VEGF injections and a total of 3 micropulse laser treatments, which then amounted to nearly 3,000 spots. And he essentially, like I said, after that last micropulse laser had remained entirely dry. So this patient really inspired us. And we've since then had treated more patients. And this is really a just mixed bag of real life patients that we've been able to pull out of our charts. It's really a nice coincidence that it's fairly balanced between males and females. The age is rather typical. And so our patients was a bit on the young side. We've included patients that had been first diagnosed with their branch retinal vein occlusion in 2015 up until early 2021. And all of the patients had to have a combined anti-VEGF and micropulse laser. So firstly, what was remarkable and keep in mind, this is really just descriptive statistics, patients who've had micropulse laser and then were looked at their visual acuity 6 to 8 weeks later remained either stable or improved, except for this one patient down here. And that was also true for their central foveal thickness, except for this patient number 10, which I'd like to draw your attention to. Again, this was measured 6 to 8 weeks after the micropulse. And this patient number 10, however, then ended up really needing very little intravitreal injections. And in fact, overall, after a lead-in phase of nearly 2 years, 64% of patients had actually had a lesser intravitreal injection environment over a course of a mean of a little over a year. So taken together, basically from our really pilot observation is that before and after micropulse, the patient remained stable with their visual acuity, suggesting good safety of the treatment. The central foveal thickness also had remained stable, also again a good safety signal. The mean pause, and I think this is really significant for a lot of patients after in this series, was 4 months. So in other words, there was a lesser demand on intravitreal injections. We had a mean number of treatments of 1.6, so we do retreat. We typically pause for about 2 months until we do a retreatment. But keep in mind that these results are not really statistically analyzed. This is just descriptive statistics because it's just such a diverse group of patients that went in there. So if you look into literature, really, there isn't a lot. And perhaps the best study comes out of Stanford from Eng and Leng. You kind of break your tongue when you pronounce it. I know Ted Leng from Stanford from back in the days. He's a very nice guy and very thorough scientist. And so they've really done a great effort in summarizing the literature out there and ended up fishing out 14 studies, out of which 3 were clinical trials, and the rest of that was just non-randomized clinical series. The take-home message is, though, that micropulse laser appears safer and as effective as photocoagulation in macular edema secondary to BRVO. If you perform intravitreal injections alone, you will end up having more visits by the patient as compared to when you do micropulse laser alone. Then that's taken together. If you actually do micropulse and intravitreal injection, you actually have a synergistic effect on improvement of best corrected visual acuity and macular edema resolution. And that has also an effect on lesser intravitreal injections, just like in our preliminary series that I've just shown you. There is a eloquent study by a Japanese group from Terashima et al. That was recently published in Retina, which looked at 44 treatment-naive patients who either had ranibizumab monotherapy or, in addition to monotherapy, received, I understand, 1 micropulse treatment, and the follow-up was 6 months. And these patients had not only a better visual acuity, but also seem to maintain their central retinal thickness, again suggesting that the addition of micropulse lasers seems to reduce treatment burden by lessening the need for intravitreal injections. These are other studies, and I guess the most significant and noteworthy is the study from Parodi et al. All the way back to 2006, which was really a landmark study that really had it's been cited many times since then. In interest of time, I'll skip over the rest here and just mention that because I've been asked to our laser settings. So we've initially used the laser settings recommended by Iridex with the 8 or 9 grids centered around the fovea. And later on, we've became much more courageous because we've really seen that there's no damage, so incredibly good safety. So we increased our spot size and number of spots that we've actually used. And I must admit that we do titrate as opposed to my Italian colleagues. But the thing is also to note that there is probably a relatively wide safety range if you enlarge your spot size. And I'd be very interested to hear why to use a smaller spot like Stella and Eduardo are using. At least if you have a larger spot size, you probably have a larger therapeutic range. So whether you titrate or not, it's probably okay if you have a fixed setting because of that relatively large therapeutic range. So just to also point out what happens if something goes wrong. So these are data from a recently published paper by a collaboration between me and a Swiss group in rabbits, where we intentionally tried to wipe out the retinal pigment epithelium with laser in order to gain a large RPE wound for retinal cell therapy. And this is a really experimental laser which uses a selective retina therapy modality. And so it really, the shorter your laser pulse, the more located your treatment to the retina is. And so the longer your pulse is, the more likely you are to induce a retinal burn. This treatment that you see here, which selectively removes the retinal pigment epithelium, is a thermomechanic treatment, and a retinal burn really comes about with a just thermal treatment. So this is a major difference in both of this treatment. This is why I'm showing this slide will actually over time reveal pigmentary changes, which we have never seen in any multimodal imaging modality we've performed on our patients over time. And we've done multiple retreatments. Some patients had up to 10 retreatments, totally safe, and are actually requesting the treatments because they feel that they benefit. So in terms of treatment recommendations for branch retinal vein occlusion, when you go into literature, you can probably find all flavors of branch retinal vein occlusion that can benefit from micropulse laser subthreshold treatments. But in my personal opinion, you probably need to look out for patients who have who are relatively early in their course of disease, because you're relying on a cytokine or heat shock response from a physiologically functional retinal pigment epithelium and Müller cells, because as soon as you have gliotic changes, then I would assume that the actual genetic profile change that you're inducing transiently with the micropulse laser might be different. Okay, so, and the overall goal, at least in our opinion, is best met that you aim at reducing the treatment burden from intravitreal injection. So in the interest of time, I will stop here and be happy to answer questions either now or after the session.
Thank you very much, Boris, for this fantastic presentation. Professor Midena, for the next presentation. Professor Midena is a very well-known scientist and clinician, and he is the director of the ophthalmology clinic at the University of Padova. He definitely can be considered the pioneer of the subthreshold micropulse laser for retinal diseases. And I can say that all the first works or papers we have published together, as we have worked together for a long time. So Professor Midena will talk now about the use of the subthreshold micropulse laser in diabetic macular edema, and I would say all the news that we have about this topic. Please, Professor Midena.
Good evening, everybody. Are you listening correctly to me, Stella?
Yeah, perfect.
Yeah, and I thank you, Stella, for a nice introduction, remembering our previous works. Really, I feel to be considered a pioneer because I trusted in this kind of laser since the beginning of the introduction of the machine in the market. And even if it is a little bit difficult today to speak about laser treatment in diabetic macular edema, because most of the people around the world are still considering the word laser as something that remember the past as the animals on your right, and the past and the images in the middle and the left part, where the burns induced by the so-called ETDRS system was provoking the loss of photoreceptors and microcytoma, as shown in the microperimetry image on top on your left. But this is no more, in my opinion, and I fully agree with people saying that this kind of green This kind of treatment should not be used in the treatment of diabetic macular edema. On the other side, everybody working in the clinics of diabetic retinopathy and specifically macular edema knows that the revolution introduced about 10 years ago by the intravitreal treatment with anti-VEGF was a partial revolution, because it has been admitted by the Susan Blesseler in particular and the Bressel family that more than 40% of people you are treating for more than 1 year with anti-VEGF, even monthly, are not responding to this kind of treatment. Therefore, there is something different. And the question is, do we have any possibility to improve the vision, function, natural history of this kind of patient, or reduce the burden of their diabetic macular edema? And if you look at the results published by the Protocol T, developed 2 years ago in the USA, sponsored by the National Eye Institute, with the 3 available at that moment anti-VEGF intravitreal injection through 3 diabetic macular edema according to very standardized protocols, and dividing the patient in well and poor seeing eyes. In any case, it was at discretion of the investigator to use as rescue treatment what? Laser. How many patients underwent laser treatment during the study? 50%, meaning that clinicians facing the monthly injections of anti-VEGF drugs were still using in 50% of cases standard laser treatment, the poor laser treatment, for trying to resolve macular edema. If you look at the guidelines for the management of this particularly retinal disorder in the middle of the retina of diabetic eyes, you see that the list by the EURETINA guidelines are a little bit well known, but I have written some points in the bottom part of the slide. One, if you use an injection, you have not to remember the loading phase, and it was correctly pointed out by the previous speaker. You should use the right drug for the right DME phenotype, because we are considering that using OCT, you may distinguish which kind of DME are you the moment fighting or need to be treated, switch or not switch in the different drugs. And the last question that I proposed to other meeting was, is laser still alive? Not the old one, not the standard ETDRS. When we are speaking about laser treatment for many macular disorders, we need currently to consider, in my opinion, only or just subthreshold micropulse, because it is, as Stella underlined, safe and working well. This is one case that from the ultra-wide field, you enlarge this one, you see some change in the middle of the macula, but if you perform the OCT, you may see the presence of macular edema. And this patient is a patient with 20/20 visual acuity. And we know from Protocol V that this kind of patient may be observed or treated. But if you see that the visual acuity maintains good a long time, and edema increases if you want to treat at baseline, I treat at baseline. In any case, which is the best treatment? Standard laser, forget. Intravitreal injection, I don't know it is so relevant to perform an intravitreal injection. We perform currently as first line, the micropulse. And as shown by the literature report, now there is consistent literature and data about this kind of treatment. Some doubts exist, and I discuss a little bit later. We, as Stella pointed, at least in our country, we are using we grown up with the same ideas, and we standardize the parameters. When we moved from the infrared to the yellow one, we maintain the concept of fixed parameters. And I discuss with you and show you data that the fixed parameters is not only effective, but safer than other consideration. I do not perform any titration. And this is the way why we are trying to diffuse this kind of treatment, even to ophthalmologists not accustomed to perform this one. We have no visible changes with any methodology, and we have no side effects as we obtained results years ago with the microperimetry. So there is no possibility using the fixed parameter to induce side effects. And on this other side, you have the efficacy of the techniques at its maximum. Moreover, the applications of this treatment, which we began with diabetic retinopathy and diabetic macular edema in particular, now move to branch retinal vein occlusion, we just heard about it, but also to other very important retinal disorders, which are able to explain to us the methodology this kind of laser work. Central serous chorioretinopathy, dome-shaped maculopathy, early age-related macular degeneration, and some other I call toxic maculopathy, meaning maculopathy used, for example, for the treatment of some systemic disorder. This I consider, Stella, a seminal work we made more than 10 years ago, because this was a randomized trial. I don't think we need some more randomized trial and some people working from pharma company assay. We demonstrated with the trial that the effect of Micropulse was, from the clinical point of view, meaning the resolution of macular edema, the same as the standard treatment. Okay, and the standard treatment was the standard laser. But what, for the first time, we demonstrated is that the retinal sensitivity improves, meaning not only visual acuity is the same, but the retinal sensitivity improves. And now I'm offering you some, not guidelines, all the algorithm we are currently using. The quoted paper is a paper we recently published, and when we analyzed a cohort of around 130 cases of naive DME eyes, just followed for more than 1 year and just treated with pure micropulse, no injection at all. But one point that has not previously discussed is the thickness of the central part of the retina. You cannot have the possibility, according to our long-term experience, to have a real effect if the retina is thicker, 400 microns. It's not related to the pigment epithelium, but to the light to cross through the retina. So the primary treatment that we are using for DME eyes, currently, standard, daily, central involving, because out of central we can treat in any case, is the treatment is safe, and therefore there is no problem. The thickness lower than 400 microns, and the interval between treatments must be or should be at least 3 months, because this is not a fast, effective treatment. You need to wait a little bit more than with intravitreal injections, for example. But treating in this way, this population, we obtain complete maintenance of visual acuity, resolution of edema, and after 3 treatments, no, on long term, we are analyzing these patients, are not recurring. Some people spoke since a couple, 2-3 years ago, about a sort of combination, combining the subthreshold micropulse to the injections. And so I provide you in this slide our protocol, our clinical daily protocol. If the thickness is more than 400, don't use directly subthreshold micropulse. And center involving, begin with a loading phase of anti-VEGF or a corticosteroid, if you prefer the corticosteroid as first-line treatment. And in 4 weeks from the beginning of the loading phase, you have to perform subthreshold micropulse, because the retina is absolutely thinner than 400. And you need to treat you need to continue to treat with the subthreshold, because if the retina is thinner than 400, you continue doing this, probably apart from the learning phase, you don't need any more treatment with intravitreal injection. And we are concluding a long-term studies performed on 3 years in a population similar to this one with very, very good results. But the story is that, and the criticism is high against this kind of technique. This was the reason why a few years ago I decided to offer a proofs how the laser really works. Because I was not completely convinced if I worked with the idea that the target was RPE and people was burning retina, and so we needed titration and something else. We were convinced about fixed parameters. And we were thinking about a different target. And for doing this, we sampled the aqueous humor of the eyes after or before performing in humans subthreshold micropulse as unique, as sole treatment. Why? Because from our experience, we are looking at the markers inside the retina, not animals, please. I don't like the animal models of diabetic retinopathy and diabetic macular edema. I want to know what happens inside the human eye, where we already demonstrated that some markers are pathologically increased in diabetic macular edema, meaning VEGF, well known, inflammatory biomarkers, previously known, some other more in detail. And what you see is over there. So they were representing a population of eyes treated with a subthreshold micropulse. And you see that compared to the controls, the pathologic DME eyes were pathologic. These are two inflammatory biomarkers, and we recently published this review. Our theory is that subthreshold micropulse modulates the inflammation in the retina in diabetes, which is one of the most important causes, at least in 50% of diabetic macular edema. And even VEGF is restored to normal. So subthreshold micropulse works at this restoring the pathologic VEGF increase. This is the reason why after injecting 1, 2, or 3 times, when the retina is thickened than 400 microns, and then I perform subthreshold micropulse, I'm working on the same pathophysiologic way. But one more important observation, which is the idea concluding my presentation, is that what happens at the retinal pigment epithelium? We are using fixed parameters. It doesn't matter of the color of the skin. It doesn't matter on other characteristics of the retina. Fixed parameters. Is the pigment epithelium biomarkers in the human eye of DME modified by subthreshold? In my opinion, no, because there are no changes. And what does it mean? It means that pigment epithelium is not involved in the pathophysiology of central serous, is not involved in the pathophysiology of dome-shaped, is not necessarily involved in many other central disorders where micropulse work, because the target of micropulse has been nominated before are other cells situated inside the retina, not at the border of the retina as it is the retinal pigment epithelium. And to conclude, I show one is an historical case. It was in our first publication, showing that 3 times treatment with the subthreshold diabetic macular edema, you have the resolution of the edema and hard exudates. And you see this one. This is at 3 months, and this is due to the decrease of a characteristically what we call inflammatory phenotype of macular edema. Then you treat and you look at a longer follow-up time at 3 months in this age where the edema is a little bit less and the inflammatory again component, or this one case, which is a little bit astonishing. On a long term, 6 months, three times treatment, you have a complete, more or less apart, this small cystic in the part of the retina with a good final near normal visual acuity. Therefore, this is my last slide and I can conclude with it. Okay.
Thank you very much, Professor Midena, for this excellent presentation. I think we have all covered a lot of very interesting points, not to say hot topics, in the field of subthreshold micropulse laser, and also all our colleagues asked that were listening to us asked a lot of questions. So I think that one of the, let's say, most important issues that we should, let's say, discuss tonight is, let's say, to try how to try to standardize our treatment. So there was a colleague that was asking if you have the macular edema treated with the subthreshold and also the anti-VEGF injection, that it is not responding to the treatment, should I increase the duty cycle from 5% to 10 or to 15%? Can we please comment on this and explain why not? Okay, please.
No. You have not to increase, because the problem is to maintain safety. And the safety in retinal disorder is just maintained with 5% duty cycle. When in the past we used different duty cycles, we provoked damage on a long term. So the possibility of the cells, of the neuronal cells, to survive is that limit the duty cycle. Then it depends why you consider a case not responding. How long are you waiting? Sometimes you need to wait not only 3, not only 6, up to 9 months. And if we go back, or you remember my slides about the biomarkers, you see that the normalization begins at 9 months after the application of subthreshold.
Okay, Boris, do you want to comment on this in your practice?
Well, I agree with Dr. Midena. Firstly, I would not increase the duty cycle, and I think I've shown this quite complicated slide from our animal experiments. The longer the duty cycle, the longer the pulse, and this really has implications for possible threshold burns of the retina, which you are really trying to avoid. And I personally would want to avoid seeing any iatrogenic damage if you don't have to have one. I mean, the modern era of treating macular edema is really one that you're with intravitreal agents, you have that the damage to the macular area has really dropped down a lot, and so therefore I think it's not the current standard anymore. And I like the analogy of Dr. Midena showing those dinosaurs in his slide, and I think that there's no need to be causing damage to the retina. You can achieve your results in most cases. I think that the secret is really that you need to get in early, and at some point, there's a point of no return. That's fine. That's true for pharmacologic agents. That's true for laser. And once the retina has reached that point, okay, well, I think that's also a message the patient needs to hear.
Yeah, I agree with you. If you want, I would just say that if you want to increase, let's say, the effectiveness of your treatment, rather than increasing the duty cycle, I would increase the number of the spots, because it is probably that you didn't treat the whole, let's say, area at the macula or the whole interested area, because a lot of people are thinking like of the continuous wavelength laser, so not doing the confluent spots and treating some just small areas. So here with the subthreshold micropulse laser, you need to treat large areas of the retina, and also to perform a lot of spots when you treat the patients. So another question that was asked here in the chat, and that I also think is a crucial point, especially when we used the fixed parameters as we showed. Is this the cutoff of the retinal thickness? So the colleagues asked, so if I have the patient, if Professor Midena can address this point, if I have the patient that has a very thick macula, should I first start with the intravitreal injections, and when should I start with the subthreshold micropulse laser? Can you please comment on this again, even if you said it in the lecture, but I think it is an important point.
Yeah. I fully agree with you, Stella. I agree with the previous comments. If you need to retreat, you may increase the number of spots, correct? Because we need a mass effect. The point is that if the retina is thicker than the cutoff or threshold, you need to inject. And in this case, I suggest you to perform a loading dose of the injection you prefer, a loading dose of anti-VEGF or one injection of corticosteroid. When checking the patient, you see that the retina is becoming thin, and it depends. With corticosteroid, it happens in a couple of weeks, no more. And with the anti-VEGF, it happens in 3 to 4 weeks maximum. You begin to treat, and you perform a standard subthreshold micropulse laser with hundreds and hundreds of spots all over the macular area. Correct? There is no difference. The term diffuse, localized, or something else are useless from this point of view. This is another novelty. This laser is not an application as the previous one. Don't think about the focal laser treatment. This is something of the historical part of the retina practice.
Okay, thank you very much. And as we all said before, using the slowest duty cycle, you can be secure to be safe when you treat your patients also in the fovea. So there was a question if the foveal treatment should be delayed just in patients that do not respond to the laser, subthreshold laser at the first or the second treatment. I would say there is no point to do that. You can treat at the first treatment, at the first laser session, also in the fovea, using these settings that we definitely know that are safe. And I would ask Boris now, there was a question about when you have macular edema and also you have macular ischemia in the retina, would you treat with the subthreshold micropulse laser these ischemic areas?
The answer is yes. We have, in fact, the patient that I've showed, and I've mentioned that in the beginning, he had significant amount of cotton wool spots when he first presented, and later on really went on having a significant thinning of his inner retinal layers in the upper temporal quadrant. And we did treat him there as well. So in fact, we don't really distinguish between sick and non-sick retina when we treat. We just have a really standardized pattern of treating the posterior pole. And just, I agree with you and Dr. Medena, basically the more spots, the better, because that way you really sort of recruiting a biofactory there, what I like to call in situ cell therapy. So that therefore I don't see a reason why to avoid the ischemic area at all.
Okay, thank you. So there are several questions about the treatment of the central serous chorioretinopathy. How soon do we treat the patients with the subthreshold micropulse laser, and if we retreat with the micropulse the patients with the central serous chorioretinopathy? So would you like to comment on this? And do you make the difference between, let's say, the acute CSR and also the chronic disease? So what would be your approach? I would like to hear from both of you. Professor Midena, please.
Yes, traditionally, in the first case, we know that sometimes in the acute phase, there is a natural resolution. So a little bit you can wait. But if you don't want to wait, or the patient doesn't want you to wait because the rumors of the media and internet and so on, you may treat since the beginning. A difference in the treating is that the amount of area of the retina that needs to be treated between acute and the chronic phase maybe theoretically a little bit different, meaning that when you have a chronic recurrence, you need to treat all the posterior pole of the retina because the disorder is much wider and you need to recruit, as Boris said, an important cell factory inside the retina to have a resolution. And once again, I point to the fact that in the past, because my theory is my theory, meaning that in the past we were convinced that CRSR was a pigment epithelium disorder. Now we know that it is a disorder mostly of the choroid. And so therefore, it's important to induce the meaning of the cell factory work inside the retina to pump out the water which is inside.
Okay, thank you, Boris. How do you treat your patients with the central serous chorioretinopathy?
Yeah, so we have a quite large population of central serous patients, and we have guidelines at our department how we approach that. And in fact, we've with the introduction of Micropulse laser, we've become quite aggressive in terms of recommending treatment to patients who walk in with acute CSR. We've had really excited feedbacks from our referring ophthalmologists that, what did you do to this patient? He came back and was essentially dry in a few days, and I've kept seeing him for weeks. And so really our threshold is really low in recommending the Micropulse laser to acute CSR patients. When it comes to chronic CSR patients, I think the picture is a bit different. I personally like to look at the fundus autofluorescence, but also the ICG, which we perform routinely in these patients when they walk in on the first time. And you can sometimes, pick up cases who seem to be acute to actually rather be chronic. And so my personal preference, and that's not necessarily speaking of my department, is that I like to avoid disappointment in patients. And so if they have what is called sick RPE, which, some patients, if they have chronic disease for years and they have these really large pachychoroid vessels spanning the entire choroid, and forbid that they actually have a small MNV sitting somewhere there, I don't recommend a Micropulse laser to these. These patients will go into either combined or single PDT treatments, which are quite effective, at least in our hands. And really, I reserve as chronic CSR patients who have monofocal disease and still relatively preserved autofluorescence and few pachychoroidal changes. So that's at least our approach.
Okay. Thank you very much. So I think one of the crucial points of the subthreshold Micropulse laser is its safety when we treat the retina. So we showed with using different settings in the sense of the not titrating or titrating, as you, Boris, that we had, let's say, a good result, but we have not had any damage on the retina. So please, in your experience with a lot of cases that you have treated, and also Professor Midena and myself that we have treated, we use the fixed parameters with the lowest duty cycle, but you also use the lowest duty cycle. Can you please comment on this, let's say, the safety issue?
Yeah, I'd be happy to. So we've acquired the laser 4 years ago in our department, and we've tested a few lasers before as well, and we felt that the Micropulse laser from Iridex that we've obtained was in the few patients that we've initially tested performed quite well, and by now we have treated roughly about 1,000 patients, and we've never seen any safety concerns, and we would get that feedback quite instantly from our private practitioners. And we also perform retreatments on single-eyed patients. In fact, I think the best example is a relative of one of my former bosses that I worked at the research department who had her only eye. And so this is a lady who basically has had neovascular AMD and had really devastating changes in her one eye that basically has gone to legal blindness now, and the other eye has a macular neovascularization type 3, a RAP lesion that really requires very frequent anti-VEGF injections, and that is monthly injections with Eylea. And at some point I treated her with Micropulse laser, and she actually responds to that every 3 to 4 months treatment in a way that she resolves subretinal fluid. She's a psychiatrist and therefore a colleague, so she can tell very well if she's functioning or not. And that lady up until now has received probably somewhere between 8 to 10 treatments, and she keeps coming back and wants to have that treatment. We've not seen any pigmentary changes in her, and I have lots of patients like that in my private practice as well, and who basically have received many treatments. Like I said, up to 10 is not surprising in our department. We typically have a retreatment interval somewhere between 2 to 4 months if needed, and that's just fine.
Thank you.
I would like to have just a short comment about the safety, because apart from any imaging technique that we know, you don't see anything about this, but with the microperimeter you are testing point by point. I can say photoreceptors by photoreceptors the retina, and even you treat and you retreat, the only point may be an improve of function. You never have a reduction in function. This means that the treatment, with fixed parameters at least, is absolutely safe over time.
Okay, thank you. I think that definitely what should we say to all our colleagues that maybe have less experience with the subthreshold retinal laser treatment, it is a very, let's say, easy laser technique, that we should change our mindset from the previous continuous wavelength macular grids. So we need to treat a lot of patients. So a huge, let's say, area of the macula, if we treat the macular area, should be treated with these continuous spots. And you should always use the 5% duty cycles. That, I think, is the definitely most important thing. And I also think that as you showed with all those beautiful cases, that as early as you treat the patients, you can have definitely better results. So this treatment can be done alone at the very early stages of the disease. So even if you have a patient with a very good visual acuity, while this patient with macular edema, you can treat the patient safely. Or you can even add this kind of treatment to the intravitreal injections in order to decrease the number of injections. So it is really, I would say, versatile. So you can use it or alone or in combination with other treatments. And tonight we have seen a lot of cases in diabetic macular edema and branch retinal vein occlusion, but we also saw that there are a lot of other indications where we can use this kind of laser treatment. So is there, before closing, because we have already, the time is running, and do you have anything other that you would like to add, Professor Midena and Dr. Stanzel, to the conclusions of this meeting that you would like to say to our colleagues?
Perhaps I go first because I'll be quick. I'm sorry, Dr. Midena. So if you're new to using Micropulse laser, all I can say, don't be afraid if you don't see anything when you treat, but be surprised when the patient comes back.
Okay, perfect. Okay.
I can only agree. And the message is that use it, try it, and then we will discuss again about the results.
Okay, there is, just before closing, Professor Midena, there is one question for you. What are your fixed parameters for 810 laser? And what about
810, the infrared laser is that 125 microns, 200 milliseconds, 5% duty cycle, 750 milliwatts, 750. This is the difference, the most important difference. Okay,
Yeah,
this
so
is the parameters for performing a very safe treatment and effective.
Yes. So it is the 3 times more, let's say, higher energy than with the yellow one, 577.
Yeah.
Okay.
Yeah.
Thank you very much. Thank you, Professor Midena, Dr. Stanzel. Thank you also to Iridex for putting this together. And thank you to all the colleagues that really actively participated in this session, asking a lot of questions. I hope that we managed to answer at least the most part of your questions. And we are obviously available. If you have any other questions, you can contact us easily, and we are very glad to respond to you. So have a good night or good day wherever you are, and hope to see you in person soon.